You're not just saying, oh, you're in crisis, let me quickly put a Band-Aid on your situation. You work with them post-crisis and help them find their dream. That's actually a question we ask people. What is your dream? And some people think we are crazy, right? But I think it's really important to remind everyone what their dream is.
This is Deep Dives by ISPU, a podcast by the Institute for Social Policy and Understanding. We explore cutting-edge research and data about issues shaping American Muslim communities, featuring leading scholars, advocates, and thinkers from across the country.
Our greatest investment, our greatest asset as a government agency is not the fancy buildings or the roads or the parks, right? It is our people. And I think investing in people and seeing what each human being that's in our county brings to the table and helping them shine it, that's what a county government can do. That's the difference we can make.
That was Madiha Tariq, Deputy County Executive for Oakland County and the first Muslim American to hold a political appointment in the county's history. She oversees services that touch nearly every part of residents' daily lives, from health and housing to justice and animal care. If you've ever tried to navigate the U.S. healthcare system, you know how overwhelming it can be. Too often, it treats symptoms in isolation without seeing the full person behind them, or the accessibility issues that may prevent them from receiving care in the first place. We can't fix healthcare in a vacuum when transportation, language barriers, scheduling, cost, or fear of discrimination can keep people from walking through the door at all. On this episode, we're discussing the importance of a systems approach in healthcare, one that recognizes the many interconnected barriers people face. We begin by hearing how Madiha's work in Oakland County tackles this challenge. Drawing on her years of experience in the nonprofit sector focused on community health, she transitioned into government to scale the impact, bringing hospitals, nonprofits, and other organizations together to provide coordinated care that addresses the whole person, not just their immediate crisis.
You know, people always ask me what it was like to switch from working in a nonprofit and into, a local government. And I always give this imagery of imagining that your vision, your mission and vision are this island that you're trying to reach, right? As a leader in a nonprofit, you are working with your team to help move, let's say you're on a pontoon boat, right? You're trying to move this pontoon boat, directing everybody on the boat to turn this way to go to the island. When you go, and so the results can be, you're closer to the ground, results can be immediate, and that pontoon boat will probably reach the island faster. In a government setting, you're doing the same thing, but you suddenly got pulled out from that pontoon boat and put on a freighter, right? The results are slower. They require there's a lot more moving pieces. But when finally this freighter reaches that island, the impact would be more macro. I think the goal, and each person on the pontoon boat would be like staff at the nonprofit, right? But each person on the freighter are organizations in our safety net. And I use this imagery of the freighter because I think that the biggest role of the county is to be that convener that can bring people together to speak the same language. We are the ones that can break the silos. And once you've centered your imagery, and your framework around that, I think it can make work. I know a lot of our community members, there's still like mistrust of government or like hesitance to work in or with government agencies. I think if you think about it this way, it can help hopefully, create more encouragement in our communities to engage more with government, because we are all part of this freighter that and it should have the same North Stars as the nonprofits. And that can only happen if, everyone on the freighter sees the same island. And for us, it's three things, right? For when I joined the county, I told my teams and our partners that we have three North Stars. One is UX, okay? user experience. The experiences of our residents need to be great. When they interact with us, when they interact with our partners, they need to be, the best that we can provide. And how do you do that? You do that by working collectively to demystify the county. So that's the second North Star for my teams and the partners that we work with. We collectively work to demystify the county. The services that the county and our state and federal government, as well as our partners provide, these are services that are paid for by our customers, i.e., our residents, through taxes. So it is our goal as a government agency to be able to provide the best customer service and the best product, right? And then the third piece is to collectively build the capacity of our safety net organizations, as well as the government agency, to be able to serve every single resident in a way that they can be their authentic selves. And this is where the disparity piece comes. This is where, our efforts to create a language justice assessment so that we can see if everybody in the county is understanding what we're saying, or our recent efforts where we extended the office hours of our clinics and our animal shelter and all these other facilities that human beings in our county use every day, but they shouldn't close at 4 or 5, right? That is not a good UX experience. So I think that's the kind of things that you can do in a government setting, where you can, and you also create an example. Most of the time we're learning from our grassroots partners, but we also create an example for them so that there's a feedback loop. At Access, when we worked through the Center of Arab Narratives, the big thing was building citizen scholars, in our community. For many, many years, research was coming in, they were very fascinated by the MENA community, because they're not a federally recognized minority, and they wanted to do this research and that research. And the whole thing that Center for Arab Narratives did was, ensure that authorship, like there's like equitable authorship and ownership of the data that's collected, that there's whatever's happening is informed by community voices. And now at the county, even though we don't do research, like we don't have a research institute, we implement this in many ways in informing our programming. So I'll give you an example. The Oakland County will be receiving a total of $38 million as part of the settlement for opiate, the crisis. And I know that there are counties who have just like taken that and been like, oh, we're going to do this, we're going to do this. Well, we were very intentional about how we spend this money. And we started the process of thinking about what to do with this money by identifying 8 different communities across the county that have had the highest levels of overdose deaths, using data from our medical examiner's office and our sheriff's office. In those communities, we hosted listening sessions, and we made the listening sessions in spaces where people could come. So not in a government building, right? Like at community organizations, at public libraries, places where people would not be afraid to show up and have their voice be heard. Their voices were heard anonymously, as well as, if they wanted to put their name in, they could. And I'm happy to report that 26% of the community members we reached through these listening sessions had personal experience with opiate use disorder. 46% of them had family members or loved ones who had been impacted. And this would not have happened if we had not actually done these listening sessions. Those personal stories of the community members helped the county identify the funding priorities that would have the most impact in our community. And there was a lot of emphasis on, staffing and infrastructure, warm handoffs, harm reduction programs. And we've already used some of these funds to, for example, create, and then we also had a steering committee with community members. And we wanted to make sure all community members are part of this committee. So we have, for example, Fatma Salman from the National Social Workers organization. We had hospital systems. So we had Dr. Shamami, who works with a hospital system working in the addiction space. We had people from the recovery community, from the Jewish community, from the sheriff's office, from schools, all coming together, looking at the data from the listening sessions and using that to create strategies or priorities. And then through our initial spending thus far has been on expanding nurse practitioner position in our harm reduction clinic, and also creating a database that helps link all of the resources related to recovery, treatment, and prevention in the same place. And then we have an RFI going out now. So instead of doing an RFP, we're doing an RFI, request for information, so people can submit their ideas. So if, let's say, Iram and Megan submit an idea that looks like similar, we will come back and say, Iram and Megan, can you work together and create a collective approach so that we can have the maximum amount of partners at the table when responding to the crisis. These are the kind of things that, I'm so grateful for my time at Access and the grassroots research that I was able to engage in there, because that helps me frame my thinking as a deputy county executive on how to reach the people, not just at the grass tops, but all the way trickle down to the grassroots.
From community work to county leadership, Madiha has seen the healthcare system from every angle. She explains how programs in Oakland County are putting a systems approach into action, ensuring that care addresses the full person, and how research like ISPU's informs these efforts.
Alhamdulillah, I'm so grateful that I get to be get to have the experience I had working on the ground and being here at the macro level. Because it had always been part of my own personal vision board to create a space where, when a person comes in for care, we're not just caring for their physical health, we're taking this holistic approach to caring for them. So when I joined the county, I've been following this approach, evidence-based approach called Transitions to Success. Even at my time at Access. Actually, I was when I was a fellow with Robert Wood Johnson, with the IRL, Interdisciplinary Research Leaders Program. My project was based on implementing this specific evidence-based model at Access. And basically what the model is it actually creates a standard of care to treat poverty. So you're not treating somebody for prediabetes or for, mental health or homelessness or whatever it may be. You're actually taking a systemic approach towards treating poverty and creating a pathway for people to either prevent poverty or, get out of generational poverty or whatever it may be, right? So, this program, Transitions to Success, we could do stuff with it in a very micro level at Access. But when I joined the county, I ended up, we ended up doing some budget Tetris in our county, health department, and ended up, setting aside funds to specifically create a program called Oakland Connects. And Oakland Connects is basically a team of community health workers that address the complex social determinants that influence our residents and their overall well-being. But we're not just doing it locally. We brought the Oakland Connects community health workers are trained in this evidence-based poverty treatment approach. And we created 10 train the trainers within the county. And now we provide this training quarterly. So through this program, we now have trained over 100 community health workers trained in the same approach across our system, whether it be hospital systems, our probation, and justice folks in the courts, schools, nonprofits, ethnic community-based organizations. So we have people all over that are trained in this space. What that has done is it has helped us learn to speak the same language. So if Iram, you come to the county, or you go to Centro Multicultural La Familia, or you go to ACC, whatever organizations, you don't have to repeat your story multiple times. And this is the whole point of Oakland Connects. Let's say when somebody has diabetes, right? You go to Dr. A and you go to Dr. B, you're going to get kind of the same, treatment plan. But if you're poor and you're suffering from poverty-related symptoms like, power got cut off, got evicted, need employment, depending on who you go to, you will get a completely different answer. So what we are trying to do is have everyone that works in this space take a step back and focus on creating a standard of care that we all follow. Now, how is that going to work with all the organizations? We've actually right now working on a data hub that we will provide, that we'll host at the county, that we will provide access to all of our safety net organizations. So that way, again, Iram's case can be held by multiple stakeholders. You don't have to go through the trauma of repeating your story over and over again. I think it's extremely validating for those of us who are trying to elevate issues around the Muslim communities at different tables. We've done our own, echo surveys that we do, like kind of our community needs assessments and community surveys. And we know that, about the MENA respondents of these surveys have reported increased difficulty in accessing substance use and mental health services, right? So like around 31%, I think, for mental health and 35% for substance use in Oakland County. To see that is like part of a larger issue across, like access as a larger issue across across the country for Muslim Americans, I think it helps us be part of a larger narrative. The other piece I'll also say is, in Oakland County, our MENA respondents were actually the ones that reported much higher feelings of social isolation compared to non-MENA populations. It was actually 54% of MENA respondents compared to 33%, which was the overall social isolation numbers. And, knowing that we have organizations like ISPU that can help elevate who the MENA community or the Muslim community is. I mean, I was fascinated to see that there is, still such a high percentage of Muslim Americans identifying as white in the report, for example. I think that reports like the ones you do can actually help us have a more strategic approach on how we address the social isolation.
From the local programs shaping care in Oakland County, we shift to a national perspective.
I'm Megan Collado. I'm a senior director at AcademyHealth, which is the professional association for health services and policy research. We're based in Washington, D.C., and guided by a mission that evidence should be used in policy and practice to improve health and healthcare for all.
Megan Collado, Senior Director at AcademyHealth, joins us to explain why funding research like ISPU's matters, how rigorous evidence can shape national health policy, and why hyper-local studies capturing the lived experiences of communities are essential for informing change on the broader scale.
Just in case the term health services research isn't that familiar to others, we sort of think of it as the field that studies how the healthcare system is doing, what's working and what isn't working in real care settings and for real people. And so we find a lot of people maybe don't consider themselves health services researchers, but are doing work that we consider health services research. And I think this work kind of fits under that umbrella as well, and is sort of looking at what is working and not working, and what are the barriers to care that Muslim Americans face in accessing healthcare. Academy Health has a long history of working with the Robert Wood Johnson Foundation to administer research grant making programs. And in 2019, they came to us and asked us to help pilot a community-led research study or research program. And they encouraged us to be bold and really think about doing things differently. And in particular, in what ways could we invert the research application process, the research itself, and then kind of the support we provide to research teams by centering community and lived experience at every step of the program design and the subsequent work. And so that important call to action to us to be bold in the development of this community-led research program led to Community Research for Health Equity, which is the program that supported the ISPU study and 9 other really fascinating studies across the country. And its primary goal is to support community-led research that elevates community priorities, especially historically marginalized populations, in decision-making to drive changes at the health system level. And so I think the ISPU project specifically and the other grants in this cohort really reflect what we believe at Academy Health and what is kind of the underlying principle of this program, which is that research has to be grounded in real-world, community-informed experiences if it's going to shape policy that actually improves people's lives. Health and well-being and wellness are really essential to people being able to live the lives they dream of. And I think that can be kind of a missed opportunity in the healthcare system where, many are so focused on the presenting symptoms and not kind of the ultimate goal that people are trying to lead. They have hopes, dreams, aspirations, pressures, other commitments. And so I think, this kind of work really shows that as we're thinking about how to improve the healthcare system, it can't be limited to just, the clinical encounter. Kind of bringing in the full real world lived experiences is really essential.
Hyperlocal research gives us a clear picture of a community's needs and experiences, but data alone doesn't drive change. To make a real impact, these insights must be translated and communicated effectively, so policymakers at the national level can understand and act on what's happening on the ground. Megan shares how this translation happens and what research funders can learn from this approach.
Our former CEO used to say, your data make you credible, but your stories make you memorable. And I think something that's really powerful about hyper-local research is it has sort of the best of both of those worlds. There's really credible data. In the case of the ISPU study, taking this kind of community systems approach was a really innovative, rigorous methodology to engage community in the research. And it elevates the many varied, diverse, and nuanced lived experiences of your community members. And so I think that is a really powerful combination for driving policy change, and one that is can be lacking at research that's at more of a national level and can't get down to the granular level of lived experiences and real stories. And I think, that connection between hyper-local and national, I loved sort of the imagery that Madiha brought in at the beginning about sort of the pontoon boat at kind of the local nonprofit, and then the freighter as you get to kind of local or county government. And I was trying to think about, I think, where I sit, I often say we have sort of the 30,000-foot view. So I think that brings us like up into an airplane a little bit. But I think kind of we have this role as a national organization to use our national presence, reach, and our own microphone to amplify local efforts. And so that exchange and sort of the communication between the freighter and the airplane, being able to bring kind of the experiences at that hyper local level into national policy discussions, and in particular, those really powerful stories that come from lived experience. And that can be done, through groups like ours that have this sort of national presence and ability to amplify local stories, but bringing that really credible local research is, I think, kind of key to policy change that reflects, local state differences. One of the primary goals of the Community Research for Health Equity program was to fund community-led research that could drive changes in health systems. So we were already bringing our lens down to more of a local policy change level. And I, in the health policy world, I don't know if others have heard this, but we'll often talk about big P policy and little p policy. Big P policy referring to typically more governmental policies. So that could be like changes in Medicaid or, other national programs, and little p policy referring to the policy change that occurs in institutions and organizations. And so for Community Research for Health Equity, we're really trying to drive change at that local system level, at the sort of little p level. And for the cohort, the studies are just concluding, so we expect to have hopefully even more examples of policy change coming out of this work. But even so far have heard examples of how this research has started to contribute to or lead to policy changes in health systems. So one of the grantees in this cohort was looking at language justice and language access within health systems for refugee populations, and they were invited by a local health center in their community to offer a language justice training for their staff. And that invitation really signals, potentially the start of a policy shift at that health center, recognizing not just the importance of language justice, but also the need for additional training for their staff, which could become a policy where they require staff to take this training. And it becomes a policy that, language access is something that is available to everyone who comes through their doors. Similarly, we have a grantee who was looking at the health of LGBTQ populations in South Texas. And from the work that they did, looking at their experiences of care, barriers to accessing care in their community, they are developing a continuing education unit, or a CEU accredited session, to help educate healthcare professionals on queer affirming care, which incorporates insights from their report. So this is the kind of, they're sort of developing evidence-informed trainings and offering them within healthcare systems, which then can be part of policy changes within those systems to serve different populations. And I think communication is something that is really central to our work as well, and sort of recognizing that, evidence can't or won't be used to inform changes in policy and practice if we don't communicate it. And I think the evidence does not speak for itself. We have to speak for it, and that can sometimes involve some translation, kind of removing jargon or other terminology that may not be familiar to policymakers or decision makers. And I think we've learned at Academy Health that translation really takes that relationship building piece. It also takes a lot of persistence. It can take quite a bit of time to build the relationships, and then sort of honing those communication skills so that you're highlighting for decision makers the information that they need at the time they need it, so that they're able to act. And I think I would add too, I think you also have to be really attuned to the policy windows, which is sort of the moment in time that opens up where policy change is possible. And I think unfortunately, we're finding ourselves in the current political environment where, instead of opening a lot of policy windows, especially for health equity focused work, many of the doors feel like they're closing. But that doesn't mean that continuing this work now and strategizing for the moment when a policy window opens isn't absolutely key. And it will open. And so I think being able to remain sort of agile, flexible, and ready to act in the moment where change is possible and those policy windows open is another kind of really important component. And I think, for you all and this report, I think there's always a lot of momentum around the release of a report. And then life continues on, and you move on to a new project or a new program, but keeping in your back pocket the ability to elevate, highlight, harness the findings and insights from this report and inject them at a time where, you might be able to crack open a policy window and use that to inform ongoing discussions. So I think really, keeping that evidence close to you and being able to share it when the time is right is also key to policy change.
Today, we've seen how healthcare is about more than treatment. It's about understanding people, communities, and the systems that shape their access to care. By connecting hyperlocal research to national policy, we can make real and lasting change. If you found this episode valuable, be sure to subscribe and leave us a review. To learn more about the Institute for Social Policy and Understanding, also known as ISPU, and our latest research, visit ispu.org. You can also follow us on X and Facebook at the ISPU, and on Instagram at @the_ISPU for updates and more content. Thanks for listening. We'll catch you on the next one.